So next I will discuss the management of adverse events with newer therapeutic approaches. Again, these are my disclosures. I'll start with an overview of cytokine release syndrome and neurologic toxicity in terms of pathophysiology and grading, and then review the results from clinical trials and the real world, specifically the incidence as well as associations with CRS and neurologic toxicity. I will discuss management considerations for both of these toxicities, and then discuss other CAR T cell toxicities, and end with a discussion of future directions to try to mitigate or avoid some of these toxicities. So, as I mentioned in my last talk, there are two main toxicities associated with CAR T cell therapy: cytokine release syndrome and neurologic toxicity. CRS is pretty well understood, felt to be caused by the activation and expansion of CAR T cells, leading to increased levels of cytokines, which further stimulate other immune modulatory cells to release further cytokines. The onset is variable in terms of the different products and the diseases that are being treated, but usually occurs within 1 to 4 days of CAR T cell infusion and lasts about 3 to 5 days, tracking peak CAR T cell expansion. And the risk of grade 3 or higher cytokine release syndrome, and we'll review the grading in a couple of slides, is also variable, but can be as high as 20% in some series. In terms of neurologic toxicity, the mechanism is less well understood, and I'll review what we know about it to date in the next slide. The onset's a little bit later than CRS, usually around day 5 to 7 after CAR T cell infusion. The duration is more variable and can be anywhere from 5 to 10 days following CAR T cell infusion. In general, it's fully reversible, except in the rare cases of fatal cerebral edema that have been seen specifically with some of the leukemia studies that have subsequently been halted. And the risk is variable, but again, grade 3 or higher neurologic toxicity, which I will review what that looks like clinically in a couple of slides, can be as high as 30 to 40% in some series. In terms of neurologic toxicity, we've learned a lot from clinical trials and animal models, and so we have identified several clinical associations, specifically patients with an increased disease burden, a higher peak CAR T cell expansion, early and high-grade cytokine release syndrome, markers of disseminated intravascular coagulopathy, and also patients with higher peak cytokines are at increased risk for developing neurologic toxicity. Similarly, from pathologic study of patients with neurologic toxicity, we can see that there is some evidence for impairment of the vascular and blood-brain barrier integrity. We also know that there are some cytokines within the CSF that are elevated out of proportion to their elevation in the blood. So we think that there actually are some inflammatory cells in the CSF that are producing cytokines, it's not just a result of passive diffusion. Interestingly, the proportion of CAR-positive and CAR-negative T cells in the CSF is similar to that seen in the blood, so it is felt that maybe these CAR T cells are trafficking into the CSF passively through passive diffusion. Because we have seen seizures, people have looked at whether there is an elevation of excitatory neurotransmitters in the CSF of these patients and have found that glutamate is elevated. And on autopsy, there's evidence of microthrombi and microhemorrhage, as well as endothelial activation and diffuse gliosis. We've seen very similar results from some of the animal models of neurologic toxicity, but importantly, we've also seen that IL-1 and IL-6 do play an important role in both cytokine release syndrome and neurologic toxicity, and it does appear that it is the monocytes and not the T cells themselves that are the predominant source of IL-1 and IL-6 that leads to these toxicities. So now we'll briefly review the grading systems for cytokine release syndrome. Most of the clinical trials use the Lee grading system, which is on the left-hand side, but in order to make the grading more objective and more consistent across future clinical trials, the ASTCT created consensus grading criteria, which are on the right. And I will not go into each of these grading criteria in detail, except to note that grade 3 and higher cytokine release syndrome is really cytokine release syndrome that requires transfer to an ICU to either to receive vasopressors or supplemental oxygen. And grade 4 or higher CRS is essentially CRS that requires mechanical ventilation or multiple vasopressor use. Similarly, for neurologic toxicity, most of the clinical trials use the CTCAE grading system, which are on the left, but in an attempt to both create a more objective grading criteria as well as make grading consistent across clinical trials, the ASTCT created consensus criteria that were more specific to toxicities that we were seeing with CAR T-cell therapy. And again, I will not go into this in any great detail, except to point out that grade 3 or higher neurologic toxicity is largely a patient who may be awake, but is unable to really answer any questions and unable to participate in self-care, or patients who have had seizures. And patients with grade 4 or higher neurologic toxicity are patients who really need to go to an intensive care unit setting because they have a level of confusion that is potentially life-threatening, or are having seizures that are potentially life-threatening. And often these patients require urgent intervention and mechanical ventilation. So when we look across the different clinical trials in diffuse large B-cell lymphoma, mantle cell lymphoma, and indolent B-cell non-Hodgkin lymphomas, you'll see varying rates of CRS, grade 3 CRS, neurologic toxicity, and grade 3 or higher neurologic toxicity based on the product and the disease. You can see that the KITE products on ZUMA-1 and ZUMA-2, which involved aggressive B-cell non-Hodgkin lymphomas as well as mantle cell lymphoma, have the highest rates of CRS and neurotoxicity, as well as the highest rates of grade 3 and higher CRS and neurotoxicity compared to products used on the Juliet and Transcend study. When used axi-cel in the indolent B-cell non-Hodgkin lymphomas on ZUMA-5, there was an improvement in the rates of grade 3 and higher, or all rates of CRS and neurotoxicity, as well as rates of grade 3 and higher CRS and neurologic toxicity. So some of this is felt to be the result of the construct itself. So one of the big differences between the products, the KITE products and the Novartis and the Juno products, are the co-stimulatory domain. The KITE product uses a CD28 co-stimulatory domain, whereas the other two have a 4-1BB co-stimulatory domain. And this is felt to lead to different pharmacokinetics in terms of CAR T-cell expansion, with much earlier and robust CAR T-cell expansion seen with the CD28 CARs compared to the 4-1BB CARs. And this may lead to an increased inflammatory response and then subsequently set the patient up for higher grade toxicity. From the KITE study, we've also learned that an increase in tumor burden and an increase in pre-treatment inflammatory markers do increase the risk of toxicity. Specifically, patients with cytokine release syndrome were more likely to have had a higher tumor burden pre-treatment, as well as higher pre-treatment inflammatory markers. And then patients with neurologic toxicity not only were more likely to have a higher tumor burden and higher pre-treatment inflammatory markers, but were also likely to have early onset and or high-grade cytokine release syndrome preceding the development of their neurologic toxicity. When we look at CAR T-cell toxicity across the real-world experience of axi-cel and Tisagen Laclusel, we can see that despite a broader eligibility criteria, we see very similar rates of CRS and neurologic toxicity compared to what we saw on the clinical trials. But most notably, if you look at the difference between studies that looked at the first year of axi-cel commercial approval and studies that included patients that were treated outside of the first year, we do see an improvement in rates of CRS and neurologic toxicity, as well as rates of grade 3 and higher CRS and grade 3 and higher neurologic toxicity. And that is owing to the fact that we have gotten better as a field in terms of treating this. We were very stingy with toxicity mitigating agents like tocilizumab and steroids early on because we thought they might impact CAR T-cell efficacy, but the data to date has not shown that. And so we're giving them more liberally, and as a result, we might be seeing less high-grade toxicity. So as we became more liberal using things like tocilizumab and steroids to treat these toxicities, the ZUMA-1 study was amended to include cohort 3 to investigate the use of prophylactic tocilizumab in all patients on day 2 after CAR T-cell infusion. 34 patients were included in this cohort. And while there was a big improvement in rates of grade 3 or higher cytokine release syndrome, rates of grade 3 or higher neurologic toxicity were actually greater than what was seen in the pivotal cohorts of ZUMA-1. This is not necessarily due to an increase in expansion of CAR T cells, but rather what we did see was that patients who received prophylactic tocilizumab had much higher peak IL-6 levels in the blood compared to patients in the pivotal cohorts of ZUMA-1. And when we looked at the CSF, you can see that there were several CSF cytokines that were elevated in patients with grade 2 and 3 neurologic toxicity in the cohort 3 compared to the pivotal cohorts of ZUMA-1. And there was an increase in mononuclear cells, specifically myeloid-derived cells within the CSF of these patients. So ZUMA-1 also included cohort 4, which looked at the early use of steroids. And so this is a slide, I will not go into it in detail, but it compares the use of tocilizumab and corticosteroids for both CRS and neurologic toxicity for the varying grades across the study. On the top are the way that these were used in the pivotal cohorts, and on the bottom, it's the way these were used in cohort 4. So you can see patients receive steroids much earlier for earlier grades of neurologic toxicity, as well as cytokine release syndrome. And in this study, when we compare it to the pivotal cohorts on ZUMA-1, you can see a much lower rate of both grade 3 and higher cytokine release syndrome, as well as grade 3 and higher neurologic toxicity. So interestingly, the outcomes were the same in terms of overall response rate and duration of response. But interestingly, the cumulative steroid dose was actually lower in cohort 4 compared with the pivotal ZUMA-1 cohorts, perhaps owing to the fact that fewer patients actually developed high-grade toxicities that required prolonged steroid courses. Cohort 4 also had lower peak interferon gamma, IL-2, GM-CSF, ferritin, and CRP levels than in the pivotal cohorts, but the peak CAR T-cell expansion was actually similar between both cohorts. You could see that using steroids earlier not only decreased inflammation without decreasing effector T-cell numbers, but actually led to a decrease in the cumulative steroid dose. And as I mentioned before, durable remission rates were similar or improved in cohort 4. So taking this to how I treat neurotoxicity, generally for grade 1 neurotoxicity, I solely observe. For grade 2 neurologic toxicity, if the onset happens late after day 5 and there's no history of early cytokine release syndrome happening within the first 24 hours, I continue to observe. However, if this neurologic toxicity is starting early or the patient had early CRS, I treat with dexamethasone. I use it at a dose of 10 milligrams, and I generally don't dose on a standing basis. I dose as needed for ongoing grade 2 or 3 neurologic toxicity. So any patient with grade 3 neurologic toxicity, I start dex exactly in that same way. Patients may need it every 6 hours, but they may need it every 12 to 24 hours. Every patient's different. So we would dose on an as needed basis. And then for grade 4 neurologic toxicity, this is when I reach for high dose salumedrol at 1 gram daily for 3 days, followed by a steroid taper. Going back a step into terms of how I treat cytokine release syndrome, which again normally happens before neurologic toxicity. For grade 1 CRS, I generally do not treat if it lasts for less than 3 days, but could give tocilizumab if patients are experiencing three or more days of high-grade fever and are miserable, and then would add dexamethasone if grade 1 CRS turned out to be toci refractory. I always treat with tocilizumab as well as dexamethasone for grade 2 CRS, largely because of that cohort 3 from ZUMA-1 study that I referenced that showed that unopposed tocilizumab led to higher IL-6 levels and higher levels of CSF monocytes. And so my concern is that unopposed IL-6 may lead to subsequent development of high-grade neurologic toxicity. For grade 3 or higher cytokine release syndrome, I always give tocilizumab with standing dex. And if there's no response, I would then switch to high-dose salumedrol. And for grade 4 or higher cytokine release syndrome, I would give tocilizumab with high-dose salumedrol. There are other agents that do cause cytokine release syndrome and neurologic toxicity, and we've seen this with the CD20-CD3 bispecific antibodies. So the mosunetuzumab study and the Regeneron studies were both presented at ASH this past year, and these treated a number of patients with B-cell non-Hodgkin lymphoma, and you can see that the rates of cytokine release syndrome are generally much lower than what we see with CAR T cells, on the order of about 30 to 60%, and rates of neurologic toxicity are also significantly lower, and rates of high-grade CRS and neurologic toxicity are increasingly low. But these are things that we do need to keep an eye out for with this other therapy that engages T cells to do anti-tumor killing. So this leads us to the question of, can CARs be safer? So there are several prophylactic strategies based on some of the clinical pathologic associations that we discussed already today. So one would be tumor debulking, since we know tumor burden is a concern. The other involves anti-cytokine therapy. So people are looking at the IL-1 receptor antibody anakinra. They're looking at the direct IL-6 antibody siltuximab, and also looking at anti-GM-CSF antibodies, given the association of monocytes and macrophages in the development of neurologic toxicity. All of these strategies are to be used prophylactically at the time of CAR T cell infusion to try to prevent the subsequent downstream clinical pathologic events that can lead to neurologic toxicity. Similarly, because of the evidence of endothelial injury in patients who develop high-grade neurologic toxicity, people are looking at the endothelial stabilizing agent defibrotide as a prophylactic strategy for CAR T cell therapy. Finally, we could think about engineering T cells so that they have a more natural and controlled activation, and thus may be safer and then potentially a more potent CAR T cell, because this potentially could obviate the problem of T cell exhaustion. So these new constructs would require multiple cell-to-cell interactions that would strengthen the immunologic synapse and improve specificity while decreasing tonic signaling. And so these include things like Boolean or logic-gated CAR T cells that only get activated upon engagement of two different receptors, or can be deactivated upon the activation of a second receptor. A concept called a tact T cell, which you actually works through the native TCR as opposed through co-stimulatory domains. And then people are also using things like CRISPR to precisely integrate the CAR T cell construct into the TCR locus, so that the expression of the chimeric antigen receptor actually happens under the control of the TCR promoter. I reviewed this in my last talk, so I'll briefly just talk. I won't go into details about this, but obviously CRS and neurologic toxicity are not the only concerns following CAR T cell therapy. We also are concerned about prolonged cytopenias, B-cell aplasia, specifically with the CD19 directed CAR T cell agents. We are concerned about relapse and the potential for secondary malignancies. And then because of the lymphodepletion that patients get before CAR T cell infusion, patients do have a protracted course of lymphopenia, which increases their risk for opportunistic infections and calls upon their need for antibiotic prophylaxis. People have started to look at the early and late hematologic toxicity following CAR T cells. And about a quarter of patients can have severe and late cytopenias, and some clinical associations that are associated with an increased risk of this are prior autologous stem cell transplant, as well as patients who have early and high-grade cytokine release syndrome. And then interestingly, people have looked at SDF1 levels and found that they correlated with late neutropenia. And the thought is that this may be a consequence of B-cell recovery, so that actually it may be the B-cell aplasia itself that sets someone up for developing the late neutropenia. In terms of risk of hypogammaglobulinemia, as well as the risk of infections, we can see that there, at least for specifically in there's some association with patients and with having B-cell recovery with risk of relapse with ALL, but this has not been seen with NHL or CLL. And so if you look at the proportion of patients who have ongoing responses versus non-ongoing responses who have either hypogammaglobulinemia or late hypogammaglobulinemia, there's no association between having that and the likelihood of having an ongoing response. In terms of risk of infections, most of the infections that patients get are outpatient, and the majority are upper respiratory tract infections. But there are a proportion of patients, up to 15 to 20% of patients, who do require inpatient care. The majority of these infections are actually bacterial infections. Similarly, this group went on to look at a whole host of late toxicities of CAR T-cell therapy, including cytopenias, hypogammaglobulinemia, infection, and other malignancies, and looked at whether patients who were in an ongoing response versus a non-ongoing response were more or less likely to be affected by these things. And there's no correlation between responsiveness to CAR T-cells and risk of these toxicities. So in summary, novel T-cell-based therapies have unique toxicities that can include cytokine release syndrome and neurologic toxicity, and grade 3 or higher CRS and neurotoxicity can occur in up to 20 and 30% of patients respectively. Both disease, patient, and product factors correlate with the risk of CRS and neurologic toxicity. So specifically, a high tumor burden, high pretreatment inflammatory markers, the CD28 co-stimulatory domain are all associated with increased risk. The incidence of toxicity has definitely improved over time, given more liberal use of tocilizumab and steroids. But what we've learned from these studies is that more is not always better, and prophylactic tocilizumab use was associated with improvements in CRS, but not in neurologic toxicity, was potentially detrimental in terms of neurologic toxicity. But earlier and more liberal use of steroids was associated with a lower cumulative steroid use and then an improvement in neurologic toxicity. Future directions aimed at improving the safety profile of these products includes new products, prophylactic use of cytokine inhibitors, and prophylactic use of endothelial stabilizing agents. And finally, late toxicities of CAR T-cell therapy involve hypogammaglobulinemia, lymphopenia, and prolonged cytopenias, and these need to be monitored prospectively. Thank you.